how would a physician implement an integrated behaviorist successfully? And I think a few lessons that I learned. One is that it took a few years to train the physicians to become comfortable in understanding what that service provided. It's not just sort of a plug and play model. You're really retraining physicians' brains and how they interact with patients and resources that they have available. So you need to have the right behaviorist, someone who really does understand the integrated model, and someone who understands the pace of the integrated model, and someone who understands that being interrupted to help is a good thing. So the things that our behaviorists had right were that they were constantly in our faces, reminding us, don't forget about me, don't forget about me, do you need help today? Or even on slow days, hey, I looked at your schedule and here's a couple of patients who I might be able to help you out with. So you want to pick a behaviorist who's willing to sort of be in your face like that and not really content being off in a corner office, sitting and waiting to help. Physicians need to work hard at embracing the model because it is a change. It's not just someone who you refer patients to, it's part of your care team. And the fears of behaviorists limiting the comfort of what you're doing as a physician, those, in my experience, are completely unfounded, and the opposite experience is real. So I would encourage physicians to pursue it sort of fearlessly, and because we all know that stress and behavioral things are what drive the major proportion of the care that we provide. And so I think if our goal is to provide the highest quality care we can, the model really does make great sense. We just have to be flexible of mind enough. Before we brought in these integrated behaviorists, I had a couple of fears. One was that it would make me less competent dealing with complicated patient situations or behaviorally anchored patient situations. And I'd say that I just sort of had this belief that that might not actually pan out to be the case. And after 5 years of doing it, I'd say that my experience was completely the opposite of that fear. That I'd say that it made me a better physician than I was before we had the integrated behaviorists. And there's a couple of reasons. Well, there's at least 3 reasons that I can identify. One, it made me a better physician because in my medical home practice, I had resources available that could help take care of my patients. Another reason is because these behaviorists, they provided education. They would teach me things. They would teach me about, oh, why don't you use this screening test? It's better for picking up anxiety. Or why don't you ask this patient this question that may be meaningful and valuable. But the third reason that I think it made me a better physician is because it also made me feel personally empowered to to go places with patients that I hadn't felt empowered before. The patient reception of having a behaviorist in the clinic evolved over time. And that was probably more about me and my perception than the patients and their perception, or more specifically, probably more about me and my message than about patient-specific things. So over the years that we worked on this model within my practice, I got better and better at helping patients understand that the behaviorist was an integral part of their care team. Whereas in the early years and pre-behaviorist days, I would say things like, do you want to go see the psychologist? I promise they won't lay you down on a couch, or things. And I would use words and expressions to try to make it feel more comfortable for the patient, because I had this perception that they would automatically not want to go see a psychologist, and I may have been part of the barrier there. But as these integrated behaviorists just became a part of our reality and a part of our practice. I think I didn't worry so much about making it okay for the patients, because it just was okay. And so I could directly say to a patient, hey, you're struggling with your hypertension control, and I think that may be because you're stressed out, and I need you to talk to our behaviorist for me to do a good job. And so my perception of patient acceptance was that it got better over time, but really I think the thing that changed was maybe me, and I got better at understanding how important their role was in the practice. One thing that I regret is that we didn't measure, we didn't have metrics that we were following. We didn't have hard numbers for ER utilization or depression management or things like that. But anecdotally, there are literally dozens of patients that I could think of, if we had an hour to sit here and tell you about, where having a behaviorist immediately available had a very substantially positive impact.
I think for me, working with the behavioral health folks here, there are a variety of different ways that we do it, but I think that the most important thing for me is when we have access to those people, when we've got an issue that's come up right away. Sometimes we'll actually have some of the students who work with our team with us during visits. Behavioral health stuff happens a lot. So, I mean, it could be anything from like the 9-month-old who has difficulty maintaining sleep at night, and there are some tricks and techniques that could be helpful for sort of modifying their behavior, to the suicidal teenager or suicidal 9-year-old. So having those folks available to us, either in the room with us at the time of the visit or down the hall, or someone who can immediately get access to, is terrific.
So I think workflow, there are some kids that I don't see as often because they can see the other person who's going to have a different perspective and bring more to it anyway. How we've used our students, been able to, they were kind of more at our elbow as part of their training. Whether it's his example about an example about a 9-month with sleep troubles or sibling rivalry or other things, I can kind of pass it off and walk away and go see somebody else. So that they've been great for that, and I think that's also a place where the students have been able to do more behavior health rather than mental health. I think their mental health need in our population is so high that even with our 2 full-time psychologists, it's still probably 85-90% of their work is mental health. They may be behavioral consequences of mental health, but we would love to do more behavioral consequences of medical disorders and early behavioral intervention, and that, we'd have to grow the program to get there, but that's where we want to go. What made this successful for us is, I think we didn't come into it with one particular model in mind. I think people debate this, what's your model? What's your model? I think we said, well, we're identifying a need and then we're figuring out how to make that need. I think from the very beginning we said, we're not going to limit to one insurance. We're going to be on the same medical record system, and we're going to talk to each other in the hallway. Now, it took years to get there, because I think for probably one of the bigger changes for the medical provider is we have to give up some things. We're used to being at the top of that pyramid and being accountable for everything, and it's like, oh no, it's okay. And that's just part, and that's also an evolution with team-based care. You're giving things up, letting other roles who are going to do it better. And so when you have to be humble enough to realize that, it doesn't take very long, that you'll find these other people are very good at these things and are going to have different training. And then really also just always trying to look at it. So from the patient perspective, does it feel like they're coming to the same place? Does it feel like they're getting the services, met, and things, so they don't feel fractured if somebody's got different backgrounds? In some ways, I think the behavioral health folks had a bigger journey to work in our setting. We have differences in style and pace and vocabulary, and it really takes a pretty special person. That's why we're real excited about having the students here. So not only are they interested in this type of work, they come in and they spend that time in that kind of work, and they're going to go out, and I think they're going to be much more adapted to working in the primary care setting, because their training traditionally has not prepared them very well for that setting. The patient's already integrated. So if you're going to have a patient-centered health system, and that doesn't mean that it's physically integrated, it doesn't mean it's under the same roof. I mean, there's a lot of different ways to do that. You can have, however you connect and communicate. Geography is just one piece of this. Financial connections and contracts is just one piece of this. what I think really matters is what it looks like from the patient. When the patient feels that they are seamlessly moving around and communication is seamlessly moving around, then you have integration. And so moving towards that, I think a lot of people really get stuck. I'm a small practice. I don't have space. Okay, who's across the street? Who could you work with? Who could you partner with? And come up. There could be no financial ties between you whatsoever, but you've figured out how you're going to talk to each other. You've figured out how you're going to reliably communicate and share information and pick up that phone when you do have an urgent need. So again, there's not one model. When people focus on what's your model, you design it around the resources in your community and you design it around your patient population. I feel like, you know, a behavioral health team can have many different disciplines. And there is, you know, people say behaviorist as if it's just one type of person. But I truly believe that the psychologist, the LCSW, and the psychiatrist are all going to bring different things. And even within psychiatrists, a medical child psychiatrist versus a nurse practitioner brings different perspectives, all valuable. So programmatically, I think we need that more psychiatric perspective. I've learned tons from the psychological perspective regarding education, brain function, and behavior. Our LCSW helps us with community resources and linking and family supports. We're still left with true medical mental health conditions that need appropriate treatment and the right medications. So it needs to be plugged in. And then they back up each other. They're bringing perspectives to each other, you know, right now. So this is again where I would push back on what's your model? What kind of staff do you have? My dream is I have it all. It's a menu of people, a menu of services. How much is on the menu and how much these things are costing is driven by my population and what resources I have available. But I need a broad menu.